So firstly, I'll start with some brief aims for today. So firstly, I will introduce you to health justice partnerships as an idea, because I know this will be new to some of you, so why they exist and what they're aiming to achieve. And then we'll explore current practice in England, drawing on my recent research. We'll have a look at some of the service models, how they're working in practice and what their experiences have been over time. And as we go through, also, I'll drop in some recommendations. So things to think about if you are designing or delivering these partnerships, which I hope will be useful for those of you who work in this field. And lastly, I'd love to hear from you as well. We will have some time for comments and questions. And as Hazel said, for those of you who can stay longer, we'll be talking about where this might go in future. So I'll begin with an introduction to the connections between law and health and the issues that health justice partnerships are aiming to address. So I'm focusing on social welfare law, which relates to the topics listed here. So these are very much issues to do with everyday life, money, housing, employment, the basic things that we need for a reasonable quality of life. And the law provides us with rights and entitlements to make sure that we can live and work in adequate conditions, and that we get support if we experience hardship or if we're treated unfairly. But some people don't access the support that they are entitled to because they may not know what their rights are, or they might not have the help that they need to navigate the welfare system and secure those rights, because it can be a confusing and a difficult process. And this is what we refer to as a legal need. And so in relation to social welfare issues, this could be things like missing out on benefits or being wrongfully denied them, having unsustainable debts, being homeless, living in poor quality housing. And these are really issues that largely affect the poorer people in society, and also people who are more at risk of hardship because of their life circumstances, and that includes people in poor mental and physical health. So these welfare issues are much more common among people with long-term health conditions, disabilities, and mental health issues compared with the general population. Obviously, poor health can affect our ability to work and our incomes, and it means that we might need more support with our finances, our housing, and other practical issues. So poor health is one of the things that can trigger these legal needs, but it also works in the opposite direction. And we know that if these social welfare issues are not sorted out, they can have some really harmful effects on health. And the link here is particularly strong with mental health because of the psychological distress that these problems can create and the way that they can isolate people socially. There are links with some very serious mental health outcomes, as well as lower level anxiety and depression. But it can also affect physical health because people may be less able to take care of themselves well. They may not be eating properly. They might be living in cold, damp environments that make them more susceptible to illness. So this is a cycle. These things reinforce each other, and we see a clustering of legal needs and poor health among the poorer people in society, and that contributes to the inequalities in health that we see across the population. So in terms of solutions, we shouldn't be thinking about these things separately either. And to break that cycle, we need to be coordinating support for people who are likely to be affected. So people who are experiencing both poverty and poor health. And this is where health justice partnerships come in. So I'm using this term as a broad definition for partnerships between healthcare and welfare rights advice services. They are a very diverse group of partnerships, but the basic idea is to provide welfare rights advice for patients through their healthcare provider. And the services that do this will very often be charities, local authority welfare rights units, money advice services. So they don't tend to use the legal language very much to describe their work, just in case that's confusing anyone. But the assistance they're providing is legal in its nature. So they will team up with the health service and provide advice for patients. And the aims here really are to reach people who are most likely to need that help, to sort out those welfare rights issues, and by doing so, to support people with their recovery and their health and well-being in the longer term. Health justice partnerships do exist across the country, and as Hazel mentioned, back in 2018, we ran a survey to identify them and just get a sense of what was going on. And it was really interesting to learn about these partnerships and see all of the different approaches. They do exist in many different health settings. They involve different types of advice provider. They focus on different welfare issues, and they have different ways that they work in partnership. So what I'm presenting today builds on this a bit further, and it looks in more detail at a smaller number of these partnerships. And specifically, it focuses on their implementation. So implementation is about how something is put into practice. It's about the structures and the processes that go on behind service delivery. And the reason that I chose this focus was because there was a clear rationale for cross-sector working, and there was evidence to suggest that this was effective from a number of different angles. But there were clear practical challenges which the previous report indicated in terms of linking those services up, getting the healthcare teams engaged in collaboration, and also keeping those partnerships going over time, because there seemed to be quite a high turnover rate. So the question becomes, if we want to do this, how do we go about it? And what is it that is likely to influence our success? So to answer that question, I worked with 9 services who were case studies for me, and I included services that were as diverse as possible, just to get a really broad picture of how these partnerships can work. And I collected information mostly through interviewing the professionals who worked there, so that included the welfare rights advice teams, the health and social care professionals, and people working in the management and the funding side of things as well. And I used mainly qualitative analysis methods. So I'm not going to go into the detail of the analysis right now, but if any of you are interested, please do ask me at the end. There are 4 main result sections which I'll present today. So firstly, we'll have a look at the service models, some of their different features. We'll have a look at the team working aspects of the partnerships, the impacts as well of those partnerships, and lastly, sustainability issues. So first topic, how were these partnerships designed? So I had case studies in different regions of the country. Some of them were aimed at the general population, and these were mostly delivered through primary care in GP practices. And others were focusing on particular patient groups, including children, people with cancer, mental health, and HIV. These ones tended to be hospital-based, but they also had outreach in other settings as well, including hospices and community mental health teams. So the most common legal issues being addressed by these partnerships were welfare benefits, debt, and housing. All of the advice services were casework services as well, so they were not just offering one-off advice, but they were actively assisting people over a period of time and helping them with things like appeals and tribunal representation as well. The advice was mostly delivered face-to-face in normal times. Obviously, things had changed during the pandemic at the time that I was doing the interviewing, and I'm sure things are still a little bit in flux at the moment. But there were 2 that were telephone-based services, and one of these had actually placed telephones in GP practices so that patients could just lift the receiver and get put through to the advice team. And the other was simply a number that patients could call and healthcare professionals could refer into. The face-to-face services were offered on-site so that patients could have their advice appointments in their place of care, and they all had some referral mechanism to receive referrals directly from the care teams into the advice service. In terms of funding, there was a wide range of funding sources for these projects. Some of them were also jointly funded, so they were bringing together pots of money from different organisations or using integrated care budgets. And there were some really interesting multidisciplinary approaches that I wanted to highlight. So 2 of the partnerships had embedded welfare rights advisors within multidisciplinary teams. And so the advisors had become members of those teams, and they were very much part and parcel of the way that care was delivered in those settings. So that was in HIV and in mental health. And that was certainly the closest way of joint working that I saw in the case studies. And there were also multi-agency partnerships. So this is where the NHS had come together with a number of local charities, so not just the Welfare Rights Advice Service, and they were working as a group to deliver a package of support for a particular population. So these ones were slightly more complex in the way that they were designed just because they needed to coordinate several different organisations, but they were providing a really broad range of support for the patients. So some things to think about in designing the partnerships, just reflecting on what I've seen. Certainly capacity is often quite limited. So one of my case studies, it was just a single advisor. Quite commonly it is between 3 and 6 people, so they're not big teams. And to boost capacity, what some of them had done was to bring in volunteers to help with some of the simpler tasks. And they'd also built connections with other local advice agencies and with local law firms for a bit of extra support with the specialist issues or providing representation at tribunals. Some were also targeting their services just to try and make the best use of the resources that they had. And they'd done this by basing themselves in areas of high deprivation or linking in with particular services where the welfare rights issues were known to be really common among the patients. If you are going for a population-wide approach, it's important to think about access within the region. And this could be particularly difficult in primary care just because there were so many sites to cover. And so what some of them had done just to make sure that they were including everyone was to link in with neighbouring practices so that all the patients could attend. You didn't have to be registered at any particular place. And also using those remote methods just to broaden out the reach of the service if it wasn't possible to cover everywhere physically. In terms of referral sources, in primary care, actually most of the referrals were self-referrals and word of mouth, also some signposting from the practice staff. And in acute settings, referrals were mostly coming from social workers, nurses, mental health practitioners, information and support centre staff. I found it quite interesting that the doctors seemed a little bit less engaged across the board. Of course, they will refer sometimes, but it is worth linking in with those other staff groups as well, and just thinking who is likely to be picking up on those welfare needs. So second topic is team working. So how were the welfare rights advisors working together with the healthcare teams on a day-to-day basis? So the most common thing was simply making and receiving referrals and also exchanging information if that was needed to support the casework. So it can be really important, for example, to have medical evidence when it comes to appeals. But there were also teams that were working together much more closely in identifying and discussing patients' needs, in coordinating the support they were providing, so liaising with each other about things, coming up with joint care plans, consulting with each other on ways forward and providing feedback on how things were developing for individuals. So there was very much more coordination in those ones. The levels of engagement did vary, and in some places it could be really quite a challenge just to get the referrals. So I was interested in what was influencing whether the healthcare teams would engage in these partnership activities. And I've broken that down into 3 broad themes. So firstly, willingness. So how positive did people feel towards the partnership? Did they value the welfare service and feel that that was something that was important for their patients? Did they recognise the impacts of poverty on health and want to do something about it? And also, were they willing just to kind of think outside the box and work with other agencies? And some of them were, they absolutely did, there was no doubt about it, very willing to be involved. Others were a little bit more reluctant and thought maybe this was a bit outside of their remit. So confidence, developing the confidence to work as a team. This was mostly an issue in the early stages before people had experience of working together. And it was things like trust. So it took some time to build up the trust between the services. Relationships were also really important, so getting to know each other and feeling comfortable as colleagues, and also just developing habits, so getting used to new systems and new ways of working, because it can be quite a big shift, both in a practical sense, but also in terms of the working culture. And lastly, ability. So this was to do with the practical things that people needed in order to engage. And that included knowledge and awareness, so that they understood what the partnership was about, what it was doing, and what their role in it should be. Also having opportunities to interact with each other so that they could speak, they could ask questions, they could discuss things and coordinate their work. And also administrative issues were important, so just having simple systems so that people could engage quickly and easily, and having all the right data protection approvals and things in place so that everything worked smoothly. So some recommendations to increase engagement just based on the experience of my case studies. Certainly promote the service to raise awareness of it, and to keep reminding people as well, because the staff do turn over, things get forgotten in the busyness of the everyday work. So the advisors were sometimes attending meetings to talk about their work, they were producing promotional materials, doing regular news bulletins, and just really trying to make sure that it stayed at the forefront of people's minds. Also provide some opportunities to learn about the partnership so that people have a good understanding of it. Again, the advice teams, some of them were offering training. They would be doing inductions for new healthcare staff, just sitting down and talking to them or inviting them in to shadow the advice sessions, and just explaining about welfare issues and when to make referrals so that people would really understand what they needed to do. Try to create some opportunities for the teams to interact as well, just partly to make that communication easier and also to build up those relationships that were so important. And this seemed to be a little bit harder in primary care just because the teams didn't necessarily cross paths as much during the day, and also in the remote services where the advisors weren't there on site. But there were still opportunities to do things like going along to meetings or away days, joining professional networks or forums, and just really trying to make people's faces known and build up some familiarity. And lastly, do provide feedback on the outcomes of the advice work. This really helped the healthcare teams to understand the impacts that the advice was having for their patients, and it increased their motivation to refer again in future as well. So sometimes this feedback was happening as part of the day-to-day teamwork where that was a bit closer, but you could also be providing regular reports for the healthcare teams just to keep them updated with the work that was being done for their patients. So the third topic is impacts. So what were the impacts of these partnerships and how did they relate to the service activities? So for this study, I wasn't measuring impacts by numbers, it was a qualitative assessment. But for those of you who are interested in the evidence base, I will refer you to the review that I did earlier in my PhD, which summarises what the published evidence has been. So here, what I was interested in was whether we would expect to see the same kinds of outcomes everywhere, or would it depend to some extent on how those services were delivered. So let's have a look first of all at the impacts for patients. Improved access to legal assistance was one of the benefits that was reported in all of the partnerships. The patients were finding their way because of the service links. So they were being referred or they were being signposted, they were seeing information in the health setting, and they were accessing that service when otherwise they might not have done. This outcome seemed to be improved where you could get more engagement from the care teams because those welfare needs were being identified more consistently, the referrals were being made at an earlier stage, and you were less likely to miss people who might need that help. The welfare advice services themselves were all achieving really impressive outcomes for individuals, and particularly huge financial gains, so getting extra income for people who would otherwise be living in hardship, preventing benefits from being wrongfully removed, having debts written off, but also some positive outcomes in relation to housing and the other welfare issues that these services were helping people with. Again, these outcomes were improved where you could get engagement from the care teams, Because people's health needs were being communicated fully, you could get access to the medical evidence that was necessary as well, and that just really increased the success rates of those welfare claims. These positive welfare outcomes were clearly beneficial in terms of mental health, and this was very evident to both the advisors and the care teams that I was speaking to. At the very least, it was reducing people's anxiety levels and really taking a weight from people's shoulders. But it had also stabilized some really serious mental health episodes, including attempted suicides. These situations, if people are having their incomes removed or they're being made homeless, can clearly be incredibly stressful for people. And getting them welfare rights advice at that point to help them through is absolutely critical. And for some people, it was a lifeline. Lastly, in terms of patient experience, the feedback from patients was extremely positive. The services were there at a time that they were really needed. It was very easy for the patients to access that help, and they were certainly very pleased with the support that they were getting from the welfare rights services. Again, where you could get that team working going, it just provided a smoother, more streamlined transition for the patients, and it made sure also that they were getting help that was really tailored to their needs, because those needs were being communicated fully. So impacts for staff as well. So for the health and social care teams, having the advice service on hand really took some pressure off them, and it meant that they could focus on their clinical roles. They no longer had to spend lots of time filling in forms or trying to help people with these really complex legal issues that they're not going to understand. It was a really big relief for some of them just to be able to make that referral and know that the person would be supported by an expert in the welfare rights issues. This is something that was reported in all of the partnerships, so simply having the welfare rights service there was a really great resource for the healthcare teams. And for the welfare rights advisors, having the connections with the care teams often meant that they could get swift access to the medical evidence that they needed for the casework. And that really just meant that they could do their jobs more effectively and get the best outcomes for the people that they were supporting. This one really depended on having a good relationship with the health service, so being known and being trusted by the care teams and by the administrators as well, who are sometimes the people that will facilitate access to that information. Also, of course, having the secure systems in place to exchange that information or to have access to the medical records. So these last two that I'll present depended on closer teamwork. So by working together on someone's case and discussing the situation, both the advisors and the care teams got a much better understanding of that person's needs. And that meant that their own work with that person was better informed. And this seemed to be particularly important where you had people with rare or complex illnesses, end-of-life situations, people with quite severe mental health or communication difficulties, because it really just meant that they had the full picture of someone's situation and they could therefore provide the best support that they possibly could. And lastly, knowledge and expertise. So again, by working closely together, the advisors learned a lot about health conditions and how they were affecting people. Certainly some of them seem to have become really expert in the issues facing particular patient groups. And the healthcare teams also learnt a lot about the welfare system and about what people might be entitled to, what kinds of information they should pass on to the patients. So there was a real upskilling of both the health and the legal teams. And that really seemed to improve their practice and the level of support that they could provide for people. And lastly, impacts for organisations. So having a partnership with the Welfare Rights Advice Service was a really valuable resource to meet the non-medical needs of patients that were clearly having a negative impact on health. And some of the care teams also found that when those welfare rights problems had been sorted out, the patients could engage more effectively with their healthcare and really get the best out of their treatment. And for the hospital-based services, it also seemed to play an important role in facilitating discharge by making sure that people had the appropriate housing and financial support in place to be independent in the community. So in terms of impact, I would say to aim for as much engagement as you can between the teams, because it will really maximize what you're able to do for people by working on things together. But I know that that's not always easy. And if it is proving difficult or not very practical, then at least really do try to raise awareness and get those referrals flowing in, because there are lots of benefits simply of connecting patients in with the legal advice and making sure that those welfare problems do get sorted out. It is also useful to make the service visible to patients so that they can refer themselves. Obviously, some people will mention to their care teams if they're having welfare rights problems, but others will not do that. It can be something that's difficult to talk about, or they might think it's the wrong place to ask, or that they might be wasting people's time. So if they can see that the service is there, it might just help to pick up those people who might otherwise be missed. So last topic is sustainability. So how do we keep these partnerships going if we want to be achieving those impacts? This was certainly one of the most challenging areas for the partnerships. So the case studies that I was working with, they varied a lot in their age. So some of them were in the very early stages, going through the pilot stage, getting set up, and others had been around a really long time, so up to 30 years at the top end there. Really, really impressive, long-lasting partnerships. 3 of them had discontinued, and that had happened at different points in their lifetime. And in all 3 cases, the issue had been to do with resources for the welfare rights advice service. 2 had had their funding removed, and 1 had had their rent raised so they could no longer afford to operate in the health setting. So in my interviews with people on the management and the funding side of things, I wanted to understand what had influenced their decisions about resourcing and whether to continue supporting that partnership. And I've split this up according to the same broad themes that I used earlier. So willingness at strategic level this time was absolutely critical, and there were a number of factors feeding into this. So firstly, did they feel the service was valuable? Was it meeting a significant need and delivering high quality outcomes? Secondly, did they feel it was relevant to their own goals as funders? And obviously those goals did vary. They had different priorities as organizations, but it was important for them to feel that the partnership was contributing towards those aims. And the last thing was whether they felt that they should be the ones to fund it. And actually this was quite a tricky issue because it's obviously not healthcare. So sometimes the health services were reluctant to fund it for that reason. But it is a service for patients. So then sometimes the councils didn't want to fund it for that reason because it was not for the general population. And also because it was clearly a critical service, sometimes the charities felt that this should be publicly funded and they shouldn't be relied on to fill that gap. So the danger is really that it gets dropped by everyone. What did seem to help a bit here was joint funding, because there were more people contributing to the partnership. It was more of a joint effort. It was a shared responsibility. So confidence was about things that were reinforcing the decision making. So evaluation was clearly very important, having some data to demonstrate what that service was achieving. The local reputation also had an influence. So some of these partnerships were really widely known and considered to be excellent. Others were much less visible, were not really known about locally at all. And that did mean that they were more vulnerable to cuts because they didn't have that kind of popular support. And the relationships between the funders and providers were important too. Often these were really strong, positive relationships. In one case, there was no relationship at all, and that had certainly put the service at risk of the cut because there was just very little communication or understanding really on either side. And lastly, ability, so how much money was actually available. This was clearly a very big factor where the funding had been withdrawn. So some of the funders were in very difficult financial circumstances and just felt that it was unaffordable within their means, even where that service was a really highly valued service. In other places, the funding was a little bit more secure. I don't think it was ever really a given just because of the economic situation that we're in. And certainly COVID had made things much more difficult for many of the funders. So I don't think it's going to be easy with the resourcing for these partnerships going forward. But I can suggest some recommendations for the local services just to support with this. Certainly evaluate your services as best you possibly can to demonstrate their achievements and their worth. Make sure that you know what the goals of your funders are and try to feed back information that is relevant to those goals. Use the evaluations as an opportunity to really tell the story and make the case for the work that you're doing. Certainly strong evaluation was one of the things that had helped these partnerships to survive some of those ups and downs. Make sure you know your funders as well and other people at strategic level. Those relationships are important for their ongoing support, but it was also really helpful to be working closely with them just to keep reviewing and improving the service and making sure that it was doing well and meeting expectations. Try to find some champions as well, particularly people in the health service who will support you and promote your work locally and help to argue the case when it comes to those difficult funding decisions. Certainly having those strong committed leaders was something that had really carried the partnerships through some of the more turbulent times. And think about how the service could be jointly resourced if possible. And that includes joint funding, which had really helped to increase the resources available to some of these partnerships, but also think about support in kind, so non-financial contributions. At the very least, the advice services should not be charged rent to operate in the health settings as a minimum. But some of them had also been provided with administrative support. So the bookings were being done by the health reception, for example. They've been provided by training with training and IT equipment and other support that just really helped to make the whole thing a bit more possible. So I will leave it there. And just to say in conclusion that these partnerships are an important means towards these goals in terms of access to justice for people who are more vulnerable to legal problems, but also in terms of supporting their health and well-being for those who are more economically deprived. And in terms of how we go about this, the service models are very diverse and adaptable. All of my case studies were slightly different. I wouldn't say there's the single best way to go about it. It's about being creative with the resources and thinking what would work well within the local context. So you could look at needs and you could be consulting with the patients and the staff to help with that design process. There are many factors which affect implementation in practice, which I've been talking about today, and there is a lot to think about. So just to recap what we've covered, these are the main results sections. And for each one, I've presented information on how things were working within the case studies that I looked at, and some recommendations based on their experiences for how to go about things as successfully as possible. So I hope that the study will be a useful resource for those of you who work in the field currently, and also for people who would like to develop these partnerships in future.